Just a brief note of organization before we start. I'm going to approach diseases of rats from a pathologist perspective rather than a clinician's. And I'm going to do that by organ system because that's usually the way, as pathologists, we interface with rodent diseases often. That's not to say that we don't participate in the clinical function in some aspects, but very often your first indication that there is something wrong is you may be looking at the slides. And so I've set this up so that we would review both rats and next mice by organ system, and we'll start from the most important, from my perspective, with the most important organ system to the least important organ system. And within each organ system, I have grouped the diseases by etiology. And that's because often similar etiologies or groups of etiologies may cause similar host responses and therefore lesions. So the organization of this allows you to, let's say, we're going to look at the respiratory system and viral diseases, and those responses are often similar, so that it gives you, when looking at the respiratory system or the lung of a rat, you see a lesion, it creates the opportunity for you to have in front of you a differential diagnosis of the diseases that I should consider when looking at rat lungs, okay? There will be more histology in this lecture than is often the case in many other similar lectures of different species, and that's partly because gross pathology is very difficult to record in rodents. All right. Just briefly, I'd like to say there are some special considerations that we have in looking at diseases in rats and to the same extent mice. And amongst those principles are, very importantly, one, subclinical infection is far more important than overt disease. And you have to be aware of this, I think, as a working pathologist. There are tremendous ramifications to this principle in research because as clinicians or laboratory animal veterinarians are used to looking at animals and for clinical signs, if there are no clinical signs, the animal is apparently normal. Many of the diseases that you may interface with as a pathologist are going to be lesions from animals that are relatively normal clinically, all right? So you have to be aware of the potential for subclinical infection to impact on the study. This would be especially so in immunological considerations or immunological studies in which measuring immune function is part of the experimental protocol. Then if you have intercurrent infectious diseases, that's going to greatly influence this. We'll look at some specific examples of that when we get to those diseases, but I've been involved in a number of cases where the animals were apparently normal and on study, and then when we got into looking at the post-mortem examination and histopathology, there were tremendous lesions present that weren't controlled for or weren't accounted for that effectively, in some cases, interfered with experimental data, and in some cases caused political problems that we had to deal with, and those cases will come up when we look at them. Anyway, remember the principle is that clinical disease is the tip of the iceberg. It's the tip of the iceberg, all right? Also, another principle is that there is tremendous strain variability in susceptibility and response to disease agents. Often the manifestations of lesions and incidences of different diseases and lesions are related to genetics and breeding. And for many different strains, each has a very homogeneous response to stress or to disease agents. Okay, and that's nice. We like to have that homogeneous response because it decreases the variability in experimental protocols. Okay, but this homogeneity of response also creates quite a divergence amongst the different strains in how they respond to different diseases and different agents, okay? So you have to view this in the light when you're looking at particular diseases and lesions. You need to be aware of what strain of animal the disease or the lesion was initially described in, because you may be looking at a different strain and the lesions may be very suggestive but not quite characteristic of classic full-blown response. So the disease is the same disease, but it looks a little bit different than classically described because you're dealing with a different strain, okay? And actually, over the years, for me, it's almost like treating these strains as different species. Fisher rats and Sprague Dawley rats, to some extent, might as well be different species in their response to certain infectious diseases or their incidence of tumors and things. And so the difference is that can be that marked, okay? Another principle that's a little bit different from our experiences in clinicians and pathologists is expect the unusual, all right? Because you look at large numbers of animals, depending upon where you work, you may see, let's say, you may see the Zimbel's glands from 2,000 animals a year, okay? Well, a lesion that occurs with a 1% incidence, if you're looking at 2,000 animals a year, you're going to see 20 cases of that a year. Well, you know, as a clinician or pathologist, you see 20 of anything in a year, and that starts to be common, all right? So you look at the pathology tables in reference books, and you see things that such and such occurs with an incidence of 1%. That sounds low. Expect to see a lot of that, okay? And then lastly, think herd health. You know, go back to those preventive medicine lectures that we all slept through in vet school. All of us did. Obviously, the people in preventive medicine didn't sleep through them, right? But remember that you're dealing with herds here and not individual animals, and herd health is very, very important. For us, it's rarely the case that we're interested in individual animal health. We're trying to think of protecting this herd, all right? And by the time that you see clinical disease, all right, by the time you've diagnosed Sendai pneumonia, the show's over. Okay, I mean, you've got this disease in the colony. It may be impacting on the immune response. It may be changing interferon levels. It's ruining the experimental protocol. So herd health is absolutely everything, right? All right, let's start with the respiratory system. And I'm going to start with viral diseases of the respiratory system. And the first disease I want to consider is Cyanodactyria adenitis virus infection, or a so-called SDAV. This is a coronaviral disease, which is highly, highly contagious. It's generally non-fatal. Both adults and weanling animals may be affected. And in my experience, there are two patterns of disease expression that we see in this. One is an endemic infection in breeding colonies, which tends to be sort of, you know, low level and very often may be overlooked. And then there are the explosive epizootics in weanlings and young adults, and that often is what is clinically visible, okay? The clinical signs we expect to see when you do have overt clinical infection, quite frequently you'll see signs of keratoconjunctivitis. There may be lacrimation. There's excessive lacrimation. The animal is exhibiting corneal opacities, which may progress to corneal ulceration. And they have this red ocular discharge that occurs, you know, as a non-specific response in many upper respiratory infections in rats. So when you see that, it's often a sign that there is non-specific a URI, but it's not going to occur only in SDAV infection because it occurs in the other upper respiratory infections as well. The animals may show signs of photophobia. There may be winking and blinking, and you may see sneezing and wiping the nose. I mean, all the things associated with upper respiratory infection, the animals may be expressing that, okay? Keratoconjunctivitis may be the only clinical detectable sign. All right, so again, good surveillance should be able to pick this up. This disease is so infectious that a single infected rat, okay, placed in a new colony is enough to initiate a full-blown epizootic. So the way to defend yourself against SDAV infection is to have a clean colony, institute the appropriate quarantine procedures, and never never let it get into your colony. Sometimes, if you're very perceptive, and if the animals are being handled and felt, the animals will develop a ventral cervical swelling, which are the salivary glands, which are the submandibular salivary glands that will swell up, and we'll look at a picture of this in a minute. But my experience, not so much mine when I was a younger pathologist, but the laboratory animal handlers picked this disease up in an institution that I worked in, and we were able to appreciate that swelling. So it is appreciable. Here's an animal with, you can see he's got this reddish discharge in the medial canthus of his eye. All right, in terms of gross pathology, the submaxillary, the parotid, and the exorbital, the infraorbital, and the Harderian glands may be enlarged, pale yellow, and edematous. They may be, the submaxillary and the parotid glands may be either unilaterally or bilaterally enlarged. And here is an example of these glands here. And I really need a normal or a control for you to see to appreciate that these are larger than they normally should be. They glisten a little bit, suggesting that there is edema there, and they're wet. Signs of nonspecific inflammation. And here is sort of an on-face view or a coronal section, just to sort of get you oriented. I mean, this is the oral cavity and the hard palate. There is the olfactory lobe of the brain, and so these are the ocular areas here, and these are the Harderian glands. And you can see here, this animal has, on the left side here, he has grayish opacity and redness, which is edema and congestion, and a little bit of swelling here, as opposed to the glands on the right side, which are relatively normal. So in this case, he has unilateral dacryoadenitis, actually, and a nice example showing that unilaterality. Again, here's a similar on-face or coronal section, and the swelling isn't quite as obvious. You can see, again, the same orientation here. The mandible is still on. There's a cross-section of the tongue. A normal gland, and here, this is a gland over here that's got some areas of hemorrhage in it. Okay, the histopathology. One of the things that you might remember is that the serous and the seromucoid glands only are involved. So the mucous salivary glands, you'll never see inflammation in the mucous salivary glands, only in the serous part. And of course, the eye is involved because of the keratoconjunctivitis. You may see thymic involvement, and in my experience, the changes in the cervical lymph nodes aren't tremendous. There's lymphoid hyperplasia, but there's not lots of necrosis or anything like that. A little bit, the histopathology depends upon the timing of when you see this. And as we go through the sort of the evolution of the lesion, I mean, it begins with epithelial necrosis, both acinar and ductular, and with that associated neutrophilic inflammation and sort of a serous, maybe seromucoid edema. It may be sufficiently severe as to efface the entire architecture of the gland. And then within a week, within 5 to 7 days, you get recovery. You get recovery by squamous metaplasia, which then becomes sort of remodels, and you get regeneration of the epithelium. And within 30 days' time, the gland is histologically normal, and there's no evidence that there was ever an infection there. Here's an example of acute sialoadenitis. And here you can see that there's a pycnotic debris and acute necrosis and sloughing of the epithelium. Closer up, again, we can see a nice example, relatively normal serous glands around here, and then here is epithelial necrosis. Maybe just as there's a little edema and separation of those acini and ducts. Now, this one's got some age on it, all right? Now we have a sort of a full-blown lymphocytic inflammatory response. There's still significant edema fluid in the interstitium, and now look at all of the squamous metaplasia here in the recovery phase of this. Again, nice piling up of epithelial, still some residual inflammation in here, and edema. A very nice slide, sort of fortuitously arrived at. This is one of the infraorbital glands, or the Harderian glands. And you can see here there are 3 lobules in this gland. And you can see the lobules are affected at different times. I mean, here is a portion of the gland that is relatively normal. Here is one that has acute inflammation, and here is one that is in the recovery phase that has the more chronic inflammatory response. And it's almost as if the infection is moving through the gland like this. So it was here first, and now it's recovery and moving here, and not quite infected that part of the lobule of the gland yet. I did mention there's a keratoconjunctivitis that occurs quite frequently in this, and here's an example of that. Here's cornea, here's corneal epithelium, and you can see there is quite a bit of acute and subacute inflammation here. There's congestion, dilatation, ectasia of these vessels, and you can see the separation of the corneal fibers here with edema fluid, all of which contributes to the corneal opacity that we see or appreciate clinically. Just a word in brief, although there is not much medical significance to SDAV infection, I think in immunosuppressed animals it can be a much more severe problem than normal. But usually this is sort of like a childhood disease of rats. You can look at it that way, and that it doesn't affect their overall health. However, I will tell you that years ago I participated in the chronic bioassay for formaldehyde. And in that study, some of you may know that the results of that study indicated that the animals on the experimental regimen developed squamous cell carcinomas in their nasal cavities, which was, at the time, tremendous significance because of the pervasiveness of formaldehyde in industry and in our culture. And so politically, this was a hot potato, in a sense. The first thing that happened in that study is that the political people, the consultants and the regulatory people and the attorneys seized on the fact that we had a transient epizootic of SDAV during that study. And it was only because the study had an 18-month interim sacrifice did we pick that up, that what we discovered at the 18-month interim sacrifice is animals with those residual recovering lesions of SDAV infection. All right? Made absolutely no difference in the study at all, and yet people who were looking for ways to invalidate the study tried to make a case that the study was flawed because they had SDAV infection. And I think ultimately the way it was resolved that it wasn't important, because it turns out that 10 years of research later indicated that while formaldehyde clearly looks like it is a chronic risk problem for rats and mice, it isn't for human beings, and that's just a species difference. But nonetheless, I mean, here's an example of a common disease, no impact on the health of the animals, that created tremendous political problems because it occurred during that study. And those are the kinds of problems that I think we have to deal with in rodent pathology quite frequently. Okay, rat coronavirus is a related coronavirus to SDAV infection. SDAV, it shares antigens with SDAV. The tightness of the relationship to it, is this a strain variability or strain difference in this? It's possible it may be an emerging virus. It's not very common. It does tend to produce subclinical disease with the same sort of spectrum that we see with SDAV infection. Both adults and weanlings may be involved. In this case, I think that the disease may be fatal in weanling rats, but they rapidly develop resistance to it, so that by 7 days, there isn't the ability to produce a fatal infection is greatly curtailed. And as an example of the variability in strain susceptibility in this, mortality in 48-hour-old Fisher rats is 100%. So young Fisher rats, 2 days of age, infected, 100% die. Similar-aged Wistar rats, the mortality is 10 to 25%. So same strain of pathogen, different strain of rat, and different variability in their response to this. So if you weren't aware of that, those strain differences, what you're seeing may be different from what you've read in the literature, and that may be because of different strains in the host. Okay. What we tend to see in this disease is focal interstitial pneumonia with peribronchial or lymphocytic inflammation, and upper respiratory lesions identical to SDAV. Sialoadenitis, however, is rare. So that probably if you're looking at salivary gland infection, you're probably looking at SDAV rather than rat coronavirus. There are ways to separate these out by serology, so getting absolute diagnosis is not a problem. So in trying to construct differential diagnoses, other things that you can consider with SDAV infection, you could obviously you should consider rat coronavirus. You need to be aware that Sendai virus, which has been described as a disease of mice originally, now has been described in rats. The same is true for pneumonia virus of mice, now is known to infect rats. Obviously, the big one to consider is mycoplasma. Other bacterial agents, and then chronic ammonia inhalation and vitamin A deficiency are problems that may also be causing upper respiratory inflammation. All right. Because I think we're getting better and better and better at environmental control and nutritional things, those diseases are kind of waning, becoming historical diseases, although as it's not out of the bounds of ordinary when you get outside the major institutions that have laboratory animal care and ACLAM certified veterinary help. Most of the major institutions now are complying with that, so we tend to get those things that decrease those spurious diseases. But nonetheless, I'm sure there are small colleges or high school institutions or things in which you may have animals that aren't complying, and you may see those things. So I think we have to keep all our options open as pathologists. This is an example of Sendai viral pneumonia experimentally produced in rats, and what we see here is the pattern of interstitial pneumonia throughout these lungs. There's nothing, I think, that singles this out as Sendai. It could be pneumonia virus of mice. Okay. Again, this is the microscopic presentation of viral pneumonia in rat. You can see again here, interstitial pneumonia tends to begin in the hilus. That's true of all species, because interstitial pneumonias usually arrive by the vascular route. They often manifest themselves in the hilar portion of the lung first. So here we have one lobe here, the hilar portion of this lung. It has increased density. And sort of up close and personal, you can see that there is, we're sort of at a little bit more chronic phase here, but there is epithelial proliferation and there is chronic subacute inflammation. And this looks like a vessel here with a lymphoid cuff around it, all right? And that's how these disease entities tend to are residual in the lung for a while, as these lymphoid cuffs remain for a while, and that may be what you see microscopically. And when we talked about mice, I'll give you some. I'll show you the results from a small study that I compiled, looking at incidences of those and how we determined that we had an in-house transmission problem rather than spurious disease. Okay. I'd like to shift to bacterial diseases now. of the lung, and clearly the most important bacterial respiratory disease in rats is chronic respiratory disease. We went through a period of time in which we began to call this murine respiratory mycoplasmosis. We got very fancy with that. And now I think that because there is a second agent, the so-called carbacillus or cilia-associated respiratory bacillus, that causes an absolutely identical disease, both clinically and pathologically, I think I've gone back to saying chronic respiratory disease because in looking at it, although most of it probably is due to Mycoplasma pulmonis, some may be caused by carbacillus, and it's pretty hard to sort those out. So for me, I've gone back to sort of the old CRD designation. It's common, it's widespread, and it's a serious problem, right? There is often a very high incidence, but a low morbidity. But the mortality is cumulative. Okay, this is a disease in which it's subclinical, it's subclinical, it's subclinical, and then pretty soon you start seeing some photophobia and maybe some upper respiratory signs, and you get kind of a sense that maybe you've got a problem, and then one rat dies, and what he's got is he's got massive suppurative pneumonia with bronchiectasis and all those lesions, and the problem is that you have other animals in the colony that are probably moving towards that route, and there's nothing you're going to do about it at that time. Because by the time they show clinical signs, they're going to die. Again, I would point out, and here's an excellent example of tremendous strain variability, right? This is a disease classically described in Sprague-Dawley rats. Sprague-Dawley rats are highly susceptible to it. On the other hand, if you're in an institution that's using Fisher rats, I have seen literally hundreds of thousands of Fisher rats and never, ever seen chronic respiratory disease in a Fisher rat. So they are genetically resistant to it. So again, in my experience, in my youthful experience as a pathologist, I went out from vet school. If you ask any senior vet student to name a disease in rats, this is the disease they're going to name. And I went to a large institution which had, again, literally hundreds of thousands of Fisher rats, worked there for several years and never ever saw the disease. So if you'd have asked me by personal experience, what's the most common disease in rats, I would not have listed chronic respiratory disease, right? Often the clinical signs, there are none initially. As I indicated, the animals may start to lose some weight. You may see this red ocular nasal discharge. That's common non-response to respiratory infection. And then as the disease becomes more severe, the animals may develop dyspnea or eye rubbing, the signs of ocular irritation, okay? If there is otitis media, and I'm going to show you an example of that in a minute, the animals may develop a head tilt. And in fact, any rat, any susceptible strain of rat with a head tilt is likely to have this disease. Either that or he's got a pituitary adenoma, okay? There is a poor correlation between clinical signs and lesions, and that's why sometimes you're often shocked that that animal is begin to show clinical signs. You decide to sacrifice that rat, and you open him up, and my God, you know, there's no functional lung tissue, and it's amazing how long he could have gone to see that. So a relatively poor correlation between clinical signs and the lesions. What you may see is early the lesions may be atelectasis, which always appear as dark red and depressed areas in the lung in whatever species we're dealing with. Pulmonary atelectasis looks the same in all species. And then classically, bronchiectasis. And it is this bronchiectasis that separates the disease from Corynebacterium cutyri infection, I think. And the bronchiectatic areas, and as you'll see in the picture in a minute, look like poorly defined nodules rather than well-defined abscesses. And it's a subtle distinction, but I think with time you can be, and experience, you can be confident about it, right? And then the inflammatory response is mucopurulent. And again, we're going to contrast that to the strep infection, which we see, which tends to be necrotizing and fibrinopurulent, okay? Here's a nice example of what atelectasis looks like. Again, we're sort of in the hilus here, but we're in the cranial aspects of these lobes, which, again, cranioventral tends to indicate that there is bronchopneumonia present rather than interstitial pneumonia. But clearly you can see these areas of depression in the lung. And here's a nice example of, it just doesn't get any nicer than this, I don't think. One of the things, one of the patterns that you see with bronchiectasis is because as the bronchi get larger, they get sort of serpiginous and they kind of get wavy, and so they produce almost a linear pattern in the lung. Okay, you can see that these are all linear going in this direction, and that linearity causes almost a symmetrical lesion. That is, the lesions look like they're somewhat organized, as opposed to the multifocal random lesions or abscesses that we'll see in Corynebacterium kucheri pneumonia. Okay, but nice example. And here these are pretty well demarcated because they're filled with mucopurulent exudate. Not technically abscesses, though. Okay. Again, you'll notice, though, that the anterior portion of the lung is involved preferentially, although sometimes the lungs in rodents are small enough that it's difficult for us to appreciate hilar distributions versus anterior ventral distributions. We can make that designation much more easily in dogs and horses and cattle. Nonetheless, it is the cranial and the ventral portions of the lobes that are involved here, and that should give us a hint that bronchopneumonia is the problem here. Okay, what do we see histologically? Well, I indicated mucopurulent inflammation grossly, and that's what we tend to see microscopically as well. And we may see it not only in the lung, but we're going to see it in the nasal cavity and in the middle ear, right? Lymphoid hyperplasia occurs. And not only does it occur in the defined lymphoid tissue, but it occurs in the bronchial-associated lymphoid tissue, or the so-called BALT, and it is a hallmark of mycoplasma infection. And partially that's because the mycoplasmas are nonspecific mitogens that induce proliferation of lymphocytes. The other things we see in response to the bronchiectasis and necrosis as a nonspecific response is epithelial hyperplasia and squamous metaplasia as the lesions get quite chronic. Okay. Here's a nice example of the hyperplastic response we see in the bronchial-associated lymphoid tissue, or the BALT. There is hyperplasia in these mediastinal nodes as well, although not quite as. Well, I'm sorry, that looks like thymus. Looks like there may be a lymphoid proliferation in the thymus. Just up close and personal with this, and you can see this is clearly a much larger lymphoid nodule than would normally be present, and that's because the mycoplasmas are nonspecific mitogens and stimulate that. Here, I think, is somewhat of a hint about the pathogenesis. What I think about is the pathogenesis of this disease. And that is, if you look at how remarkably proliferative the lymphocytes are in this disease, that they impinge upon the airway, and not only that, but I think they destroy the wall of the airway, and I think in so doing, the airways lose their ability to contract and maintain shape, and so they expand and become ectatic. All right. And here's an example of the squamous metaplasia that occur. This should be, when you think about it, this should be respiratory epithelium, right? I mean, it should be pseudostratified, ciliated epithelium, and it's all squamous. There are other manifestations, and it may be in your particular experimental protocol. You may be sectioning the nasal cavity. Certainly when we did the formaldehyde study, we were looking at 7 different sections of the nasal cavity. All right, and so you may see nasal cavity manifestations of this disease, and in fact, there is mucopurulent exudate in here, which we'll look at, and the nasolacrimal duct comes down through here. We'll look at that in a minute, and we'll see that there's inflammation in the nasolacrimal duct. Yeah, see this? So this is the nasolacrimal duct, which is extending from the conjunctival sac down through the nose, And you can see that there is an inflammatory exudate in here, so the inflammation is contiguous. Here is a series to point out to you again, cross-section through the whole head. Here's the brain, and here's the middle ear. Here's the middle ears, and you can see, this side's got something that this side doesn't have. And what that something is this big ball of pus in here. And it looks like it's eroding in here to the 8th cranial nerve, and that is, in fact, what it is doing. And here is the 8th cranial nerve, and here is suppurative exudate, and this is acoustic neuritis, all right? And this animal had a head tilt, and all from mycoplasma. All right, the pathogenesis of this disease is strongly associated with ammonia, all right? Which is one of the reasons why rodents make a lot of urine. Obviously, the urine has a strong ammoniacal component to it, and that's why one of the reasons why ventilation or airflow in rodent rooms is vitally important. It's vitally important to have sufficient airflow and to direct that airflow so that the animals are not breathing in this ammonia vapor. And the reason why that's important is one of the things ammonia does is cause ciliostasis. So if you cause ciliostasis from whatever, but certainly in rodent housing, ammonia is one of those things, we have reduced or severely compromised one of the pulmonary clearance mechanisms, and we have provided an opportunity for the mycoplasma to invade and establish themselves. Okay, so we began to see less of this disease when we started to pay attention, close attention to airflow and take care of the air handling properties, and that reduced the incidence of this disease quite a bit. I mentioned that Mycoplasma pulmonis is a potent mitogen, which is why we tend to see lymphoid hyperplasia in the balt in this disease. And by the way, that's a hallmark of Mycoplasma infection in other species as well. Again, I mentioned, I think that part of the pathogenesis is that the lymphoid hyperplasia can be so intense and infiltrate the wall of the airway so much so that you destroy that wall, you destroy the muscle, and the wall and the airway can't contract anymore, and so gradually starts to expand and expand and expand and expand. And I think that may be part of the answer to why we get bronchiectasis. And of course, as you begin to do that, as the airway begins to dilate, all right, we change the surface area volume relationships in that portion of the airway. And in so doing, we have now tipped the balance of particulates coming in and being removed by the clearance mechanism, and so that predisposes to bronchopneumonia. And that, in a nutshell, is the pathogenesis to chronic respiratory disease. I don't want to say a lot about Carbacillus. I don't need to. You need to be aware that there is a second bacterial agent, which is a gram-negative filamentous rod that colonizes ciliated epithelium and causes lesions identical to Mycoplasma pulmonis. And here is an example of this. You need special stains or you need electron microscopy to see the bugs, but what you appreciate here is mucopurulent bronchiolitis, and you have to give that some consideration. Here is a silver stain. You can see the Carbacillus sticking right into, adhering right to the cilia on the respiratory mucosa. And so there is a hint that you certainly wouldn't see those with Mycoplasma. And electron microscopically, you can see how these things are marvelously adapted for inserting themselves on these cilia, and sort of like, they're about the same size as cilia. It's almost as if they're hiding in here, although I don't know who they're hiding from. Nonetheless, this also inhibits the movement of cilia or creates ciliostasis, just like the Mycoplasma does. And that's a pretty fundamentally important process. I mean, remember that the cilia are, when you think about the main defense mechanism in the lung, is a sheet of flypaper being rode by cilia, right? And pulmonary defense or clearance depends upon the stickiness of that flypaper and the action of the cilia moving the flypaper and what's been trapped in the flypaper out of the lung, or out of the airway, all right? So anything that's either going to dilute the flypaper or inhibit the flypaper is going to interfere with that mechanism. And also, if the rowers, the cilia moving that flypaper is impaired, you're going to get failure of clearance and eventually accumulation of particulates, and you're going to get pneumonia. So that's the pathogenesis of those two. Okay, pseudotuberculosis. Pseudotuberculosis is caused by, it's kind of an odd, obtuse name because pseudotuberculosis may refer to a couple of different diseases, and so there's some confusion. But well established, caused by Corynebacterium kucheri. I think that, as far as I know, the microbiologists have been busy reclassifying other bacteria and haven't gotten around to this one yet, so it's still permissible to talk about Corynebacterium. It's a disease that occurs in both rats and mice. As with chronic respiratory disease, it is primarily a subacute respiratory disease in rats, right? So this is another one of those sort of low morbidity diseases in which subclinical infection is more common than clinical disease, and you may see it when the animals are stressed, or the disease may be enhanced or brought to a clinical level or increased in severity when it's stressed. Animals are stressed, and that experimental manipulation, and if you, again, you have a low incidence of this, it's there, the animals are handling it, and then whatever your experimental regimen may be, boom, the animals now begin to express lesions or get disease, and then you get an epizootic. Okay. It's probably an aerosol infection, but when you look at the pattern of disease, as I think is true for a number of other corynebacterial diseases in domestic animals, there is a hematogenous spread involved. And so this disease, I think, in my experience, doesn't present as bronchopneumonia. It presents as multifocal abscesses. And that multifocality suggests a hematogenous spread to me. And I could cite other examples. I think that those of you with experience with rhodococcus infection in horses recognize that there's sort of two levels of expression. There is a chronic pulmonary abscess bronchopneumonia syndrome in the older horses, but young foals tend to have a metastatic shower to the lung. And so I think it may be related to the level of the immune response and whatnot. Epizootics do occur. I was privileged, I guess I was lucky to indirectly have been involved in an epizootic to this disease in what shall remain an unnamed but major industrial company on the eastern seaboard that had this disease, and the inexperienced laboratory animal veterinarian, not a ACLAM certified in-house veterinarian, but somebody that was sort of came from the outside, made the mistake of trying to treat the disease. And of course, in trying to salvage the experiment, and ultimately what happened is, of course, by keeping those animals in the colony, just spread the disease to the other animals in the colony, and they wound up spending more money rather than sacrificing the animals and starting the study again. They sort of delayed the agony and eventually wound up spending more money than they would have in the first place. So, again, the clinical signs that we see are nonspecific. We may see this porphyrin-stained oculonasal discharge, or this reddish oculonasal discharge, common in many different respiratory infections. You may see nothing, and then the animals might die. So again, somewhat similar to chronic respiratory disease. And I think that corynebacterial agents, as the mycoplasma agents, tend to be agents of low virulence, so that you can have lots of infection without creating death. That's not the case with some other higher virulence agents. Okay, what do we see grossly? All right, as opposed to chronic respiratory disease, in this case, my experience is that you see miliary to coalescing white foci, which are well demarcated and maybe caseo-purulent. These may coalesce to involve large portions of the lung, and if they break out into the pleura, you'll see pleural adhesions. And again, I think the pattern indicates that there is hematogenous dissemination of this disease rather than classic bronchopneumonia. And here's a nice example. Again, in my experience, I saw a lot of this disease in horses when I was in Texas, in young horses. And I mean, I could take the scale bar away from this and tell you that this was the lung from a foal, and you wouldn't know the difference. This is exactly what Rhodococcus equi looks like in foals, not adult horses, but in foals. And again, we have a tendency, you know, what we see here is we see multifocal coalescing white foci, which are little pyogranulomatous, or early they're abscesses, and then with time become pyogranulomatous, okay? And that's the pattern that you expect to see in disseminated disease or hematogenous disease. Clearly, hopefully, you could differentiate between this and the Mycoplasma pulmonis bronchiectasis lesion. And here's one that's gone a long time, and we've got clearly, there's been coalescence. I mean, look at these lungs again. Far advanced disease, a sense that there's some abscesses here, but in some respects, the whole lung is an abscess by now. Histologically, again, what we see with pseudotuberculosis is coagulative to liquefactive necrosis early that becomes suppurative, and then it progresses to pyogranulomatous with time. No giant cells, no mineralization. And if you suspect that you're dealing with this disease, the nice thing is that they're gram-positive short rods that can be well visualized by the appropriate gram stain or special stain. And here's an example of Carinibacterial, again, the microscopic or the subgross from the gross that we looked at. You can see there's lots of individual little pyogranulomatous foci here. Looks like there's some lymphoid hyperplasia in the hilar nodes, should be expected. And again, this is, in fact, this is case material from that industrial outbreak that I mentioned to you. And again, look at these discrete areas of pyogranulomatous inflammation that are coalescing. Yeah, I don't know whether it's coincidence or not that it's right next to this vessel, but again, this looks a little bit different than, it's not in an airway. The typical pyogranulomatous focus in the lung, not an airway, so not a not an ectatic airway. And then when we're appropriately stained with a brown brin, you can make out the gram-positive rods here. So there's one that you can relatively easily, definitively diagnose. Okay, a disease that probably isn't as common as it used to be is streptococcal pneumonia. This tends to occur as an acute epizootic disease in young rats. It may be part of the normal nasopharyngeal flora that is kept in check by normal immune mechanisms, and then when the animals may be stressed or suffer immunosuppression from stress or some protocol manipulation, boom, you know, their immunity may go down to the point where this pathogen can establish itself, and then it may be spread by aerosol and spread to other animals. Okay, the clinical signs associated with this, again, are the nonspecific signs associated with upper respiratory tract infection, rhinitis, mucopurulent discharge. We may see this porphyrin-stained oculonasal discharge. The animals may be snuffling, and there may be some dyspnea, so clearly the clinical side of you would recognize that maybe the animals are experiencing respiratory difficulty, and they often die within a few days. And what you see grossly here is a little bit different than the two previous respiratory diseases, and that is we tend to see fibrinopurulent bronchopneumonia with pleuritis and pericarditis. It really, it's the shipping fever It looks like Pasteurella, somewhat like Pasteurella that we would see in ruminants. Okay, it's very effusive. So no bronchiectasis, no chronicity, no ectasia, but diffuse exudative pneumonia. And as streptococcal diseases in other animals, as you know from other animals, there may be hematogenous dissemination to meninges, so you may see suppurative meningitis, and we may see lesions in liver, kidney, and joints, and that's less common in my experience than the pulmonary infection. Histologically, what we see is acute exudative pneumonia that is rich in fibrin and neutrophils and erythrocytes. Again, it would be very similar to what we would see with Pasteurella, like a shipping fever in bovine, or strep pneumonia in pigs. Again, here, the key here is no abscesses. And it's not very common, and here's an example of necropsy, and what we're looking at here is the lungs and the heart and everything just covered with fibrinous exudate. So again, this would be unusual in the other two diseases that we looked at. Here's an animal with purulent rhinitis that has strep infection. This is what the subgross looks like. Again, we see there's no tendency towards ectasia or abscess formation, but this is just diffuse fibrinopurulent pneumonia. And again, this is a sort of up close. I mean, here is necrotizing bronchiolitis and fibrinopurulent inflammation, and alveoli from the same. So necrosis, fibrin, neutrophils, lots of destruction. Okay, mycotic and parasitic diseases, which will be the next consideration, and the first one I'd like to talk about is so-called Mneumocystis Cariniii, and it's nice that I've sort of lumped mycotic and parasitic together because there seems to be some controversy about whether pneumocystis is a fungus or a protozoal parasite. I think that the people that are doing looking at RNA analysis and RNA homologies believe that this animal now, or this thing now, looks like it falls out more with the fungi than with the protozoa. There's lots about the reproductive aspects of this and the life cycle of this that mimic a protozoal parasite. Anyway, it is a very commonly occurring latent infection in rats, to some extent also in mice, and clinical expression usually relates to immune suppression. So again, we've learned a lot about this disease since the advent of AIDS in humans. And in fact, a lot of these opportunistic infections that we used to look at as being sort of unusual, sporadic diseases, I think since the advent in AIDS and our understanding of immune suppression has brought to light many of these diseases and helped us understand the pathogenesis of them quite a lot. The clinical signs of this disease are vague. Severely affected animals may exhibit dyspnea, but I will tell you in my experience, I even spent some time a number of years ago trying to reproduce this disease so that we could get grant money to study this. And we had animals on the classic immunosuppressive doses of corticosteroids, and we were able to produce Corynebacterium couturi infection very successfully, but never produced pneumocystis pneumonia. And in my experience in the disease is that it's occurred as sporadic areas of inflammation in the lung, but we've never produced enough disease to cause clinical signs. Okay. The gross pathology in the prolonged, in the really severe cases, is that of an interstitial pneumonia. The lungs are enlarged and firm and rubbery. And histologically, we see the signs of interstitial pneumonia, that is thickened alveolar septi that have increased cellularity. The characteristic lesion in this disease, though, is this eosinophilic foamy alveolar fluid. And usually, you can't see the yeast-like organisms without special stains, but you see these multiple foci of this foamy eosinophilic fluid, and your level of suspicion that this is Pneumocystis pneumonia should go way up. Okay. And here's an example of one of these foci, all right? So multiple alveoli involved. Looks like there's some pycnotic debris in here and some sort of serofibrinous exudate, but not a lot of inflammation. Just up close and personal, the bug does cause damage to type 1 pneumocytes, all right? And I think the pathogenesis of this disease, here's an example of, with the special stains, you can see that this is this is a reproductive phase of the organism, and these are sort of spent shells of that, okay? But anyway, with the appropriate gram-methenamine silver stain, you can see organisms. The pathogenesis of the disease, I think, has worked out pretty well, and that's partly because the disease is such a common and devastating manifestation in acquired immunodeficiency syndrome in humans that we've come to know more about it. It is a latent infection. Probably clinical disease occurs when there is failure to clear the infection. The organisms then proliferate. They do attach. We do know that they form an attachment to type 1 epithelial cells and cause degeneration and exfoliation. And as you may remember, the real barrier in the air-blood barrier, all right, I mean, the air-blood barrier represents capillary endothelial cell, a very thin, very dry, nascent interstitial space, and then on the other side of that barrier is the type 1 pneumocyte, and the type 1 pneumocytes are locked together very tightly, and that's really the barrier, so that there is some circulation of plasma in the interstitial space, but it's rapidly sucked up by the lymphatic system because it's very important for the lung to be dry. All right. If anything that happens that loosens that very tight cell-to-cell junction of the type 1 pneumocytes will now allow flooding of the alveoli with edema fluid. And that's very important in the pathogenesis of this disease because we know that the pneumocystis organisms cause that damage and the cells contract a little bit and open that space up, and so that's why we get tremendous leakage of plasma into the lung. The agent is of relatively low virulence. All right, so I mean, how it causes this damage we don't know, but from what we know about the clinical disease in humans is that humans that die of this disease at autopsy, they have nearly 100% of the lung involved with this. Okay, as opposed to, let's say, in streptococcal pneumonia, because streptococci secrete an exotoxin, you have one lung lobe that is involved, and that may be enough to cause death. Whereas I think that the cause of death in this is respiratory insufficiency. That's why these patients last a long time. You can clear the infection a little bit, and they can get back to some sort of respiratory capacity. So it's very much a chronic disease of respiratory insufficiency, and death is not caused until almost the entire lung is overwhelmed. I think that's why we don't see a lot of clinical Pneumocystis Cariniii in rodents, because it never gets to that point. Okay. All right, just a brief note about neoplasms. Primary lung tumors in rats are relatively rare. You may see lots of bizarre metastases. This is a metastatic C-cell carcinoma in the lung. Here's an example of a malignant trichoepithelioma from the skin that metastasized to the lung. So again, we talked about rare things. Rare things happen, and you will see them. And just a couple of miscellaneous problems in the lung. This is an example of corn oil aspiration. and animals that are being gavaged in corn oil vehicles. You put the gavage needle in down the wrong tube, and you squirt that corn oil in there, and the animals go like this, and that aspiration kills them. And what you see is this refractal stuff in the alveoli out by the pleural, because when they gasp like that, it sucks the corn oil out to the margins. And then lastly, here's an example of heat prostration. And the lesions of heat prostration is just visceral congestion. But this is a consideration if you live in tropical or hot climates, and the animals arrive on the shipping dock and they sit there on the box out there on the dock for a while, and they'll overheat and die. So not a problem for the guys in Anchorage, but I can tell you I've seen this in Houston. So, all right, shall we take a break? The second disease, the second organ system we'll consider is the gastrointestinal tract, and obviously the gastrointestinal illnesses are important in rats, which is why we'll consider it now. Starting with the viral diseases, there aren't many viral diseases in the rat GI tract that are important, but cytomegalovirus, which is a herpes virus, is certainly one of them. This again tends to be a latent, usually subclinical infection, in my experience, of the salivary glands. Generally there's no disease, but there's mild non-suppurative adenitis, and this is likely to be an incidental finding for you, and what you typically see would be intranuclear inclusions or cytomegaloviric inclusions in epithelial cells, and here's an example of just such an example of this. Again, the animal was clinically normal, but in screening the tissues, neoplasm, again, bacterial diseases. Just let me briefly mention that there is Tisser's disease and salmonellosis, which I'm going to cover in detail in mice, because the material that I have is more referable to mice. Mycotic and parasitic diseases, again, are similar to the mouse in that there is Giardia, spironucleus, pinworms, and Hymenopus, but I'm going to cover those when we look at mice again. Neoplasms are uncommon, with the possible exception of colonic adenocarcinoma in Wistar-Firth rats. And I mention this because there is a very high frequency, and the Wistar-Firth colonic adenocarcinoma might be a model for the similar analogous disease in human beings, so may be useful in that regard. We've sort of jumped all the way in the gastrointestinal tract to miscellaneous diseases, and certainly one of them is malocclusion, which is what is pictured here. The hepatobiliary system is the next system I'll consider, and we'll start with the viral diseases again. And the viral disease of choice is the Kilimrat virus, which is a parvovirus. This is also, in some of the literature, you'll see this indicated as Tulin's H1 virus. The typical response, again, it tends to be a latent disease with subclinical infection. There may be sporadic disease among neonates and sucklings. Because it's a parvovirus, all right, like all parvoviruses, it has a predilection for rapidly proliferating cells. And so we tend to see the lesion expression in organs and tissues in which there is rapid turnover, okay? One of these organs in neonates is the liver, hence why we see parvoviral hepatitis in the rat liver, okay? And histologically, what we'll see is hepatocellular degeneration and necrosis with intranuclear inclusions, which I'll show you in a minute. This disease tends to be clinically severe or more severe in animals between 6 and 12 days of age, and then after 12 days of age, it becomes a self-limiting hepatitis. And here is an example of sort of a non-specific hepatitis in a neonatal rat, and hopefully we'll focus in on, yeah, here's the internuclear inclusion, nice parvoviral inclusion in this rat. There is a manifestation of this disease in the central nervous system, which we'll get to when I talk about central nervous system lesions. Okay, bacterial diseases. And the differential diagnosis for bacterial diseases, and again, we're going to talk about bacterial diseases in more detail when we cover mice, but the bacterial diseases to include in hepatitis, causing hepatitis, is pseudotuberculosis, which causes abscesses, Tisser's disease, which tends to cause acute necrosis, and salmonellosis. Those would be the common bacterial disease problems causing hepatitis in the liver. A note, salmonellosis can be very common in mice, but not common in rats. Okay, in the classification of mycotic and parasitic diseases, certainly one is Cystocercus Faciliaris, which is the intermediate stage of the cat tapeworm Taenia taeniiformis, and that makes sense that cats eat small rodents and that the rat should be an intermediate host for this parasite. It tends to be an uncommon incidental finding in lab rats, as you might guess, because the transmission requires the consumption of the egg stage by the rat, all right? When one begins to find too many of these in one's rat colony, it's time to call Charles Rivers and discuss with them how they're raising rats, because they have to get access to cat feces, and so it clearly represents an unsound housing practice problem when you've got cat tapeworms in your rat liver, all right? In my experience, it's usually single, but there may be multiple. I have seen livers in which there are multiple Cystocercus in the liver. But here's an example of one that's, they tend to be discrete, sort of, the bladder worm is a sac filled with edema fluid and the scolex, and microscopically, when you section that, this is what you see. It's an encapsulated fluid mass with a larval stage of the tapeworm in that, okay? There's no, other than the fact that it compresses the liver parenchyma, there probably is no functional significance to this, at least in the sporadic cases, and probably even in the heavily infested cases, there probably is no adverse effect on the animal, because the liver has a marvelous amount of physiological reserve and some regenerative capacity, so there's not a lot of virulence associated with these. It's a space-occupying lesion. There is some evidence, as occurs in a number of different parasitic infections, there's some evidence that these cystocercus may induce fibrosarcomas in the liver. So there's some of that, but I don't think it's a real common problem. The other parasitic infection that occurs is Capillaria hepatica, And this also is uncommon in laboratory rats, although both this and the previous parasitic disease would be more common in feral rats. Again, because the acquisition of the parasite requires consumption of infected liver, one has a legitimate basis to discuss the quality of the animals that you're purchasing from whoever your supplier is if you see too much capillary hepatica in your animal colony, all right? This is a typical appearance of these bipolar eggs. There's almost nothing else that causes this in rats that I can think of. Neoplasms, hepatocellular carcinomas are quite common in rats. The terminology is confusing, and I'm not going to go over it here because somebody comes along and rechanges the classification of these every few years. But suffice to say that there is a gradation of these from basophilic foci or clear cell foci to neoplastic nodules to adenomas to carcinomas. There's a regular progression about which we argue the terminology, but the fact is that there is lots of malignant transformation going on in the rodent liver. Many of the xenobiotics that rats will metabolize in studies are metabolized in the liver and so stimulate this. So hepatic tumors in livers are quite common, and you'll have to deal with their incidence and classification at a later time. I've just included one example. This would be a typical full-blown hepatocellular carcinoma. As in many species, the carcinomas tend to be pretty well differentiated. I've had experience, just recently had experience in my biopsy practice that in a really well-differentiated hepatocellular carcinoma, if the clinician or the surgeon takes a small piece of tissue and he takes only tumor tissue without history, you may have a difficult time diagnosing the fact that there's a tumor because it looks so well differentiated. So often, if you have adjacent liver next to it that's normal, you can see that contrast. Shouldn't be a problem for you with rodents because you kind of get to pick and choose what you look at. You get to see the whole liver, so diagnosis shouldn't be a problem. The nervous system, next. And in considering, we'll start with viral diseases in the nervous system. And I'll pick up with the Kilimrat virus or the parvovirus, as we talked about in hepatitis. This is a disease that occurs in rats only, so it's species-specific. Generally occurs in adults and weanlings. And it's a situation, again, where infection is common, but clinical disease is sporadic, and usually what we have is latent infection that's reactivated by immunosuppression. Okay. It is a viral infection that crosses the placenta, so it creates the possibility of vertical infection. And in production colonies, we haven't talked too much about what you see in production colonies, but decreased production. That is, if you're in the rat-making business and you notice that there is a decrease in production, that's often a sign that there's a problem, right? Well, there are lots of things that can result in that, of course, but infectious disease should be in the list of things that you would be looking at. The animals may get icteric if they have hepatitis associated with this, and if they have CNS or have encephalitis, then you may see ataxia. Again, as with most parvoviruses, the virus has a preference for mitotically active cells, which explains the distribution of the disease. In this case, there is cerebellar hypoplasia, and there may be intranuclear inclusions in the cerebellum, and that's because at the time they're infected, the cerebellum may be actively proliferating. My experience with this is this so-called hemorrhagic encephalopathy. There has been some things in the literature in the past 10 years or so describing this. I don't know that there's anything specific about this. We know that there is a viral tropism for the endothelial cells that causes endothelial damage and thrombosis, and the thrombosis probably is the basis for this hemorrhagic encephalopathy, as it tends to be infarctive. Okay. And you may see inclusion bodies in the endothelium. Again, I wish I had slide material to show you in color. This is black and white of the dorsal surface of a rat brain with hemorrhagic encephalopathy, but certainly you can see the extent of hemorrhage over the cerebral hemispheres. And here that also extends to the spinal cord. Here is severe hemorrhage in the spinal cord in this disease. There's almost nothing else that does this that I'm aware of. And here, there's nothing special about this. Again, that there is probably this separation here represents necrosis from ischemia, and probably some of that is handling artifact, but nonetheless it indicates that, you know, carefully handled normal brain tissue shouldn't do that. So here all of this congestion and hemorrhage is all secondary to the disease. And here is a nice example of endothelial necrosis. There's no inclusion bodies here, but there's clearly endothelial necrosis in this specimen, which is virally mediated and probably is the pathogenesis for thrombosis and then ischemia. And again, similar in the spinal cord here, there is hemorrhage and there is lots of edema in the white matter here. Okay, bacterial diseases. Again, the bacterial diseases in the central nervous system of rats are not particularly common. I mentioned the Corynebacterium. Corynebacterium is going to causes metastatic disease nearly everywhere. And again, we'll discuss that with mice a little bit. And let me point out that otitis media, partly respiratory, partly nervous system, but otitis media as a function of Mycoplasma pulmonis infection should be considered. When we get down to mycotic and parasitic diseases, we have a tendency to think of encephalotozoan as being the more common disease in rabbits, but I would point out for you that encephalotozoan has been reported in rats and mice as well. And here's a relatively typical, for those of you that have seen this in rabbits, you would recognize this lesion is the same wherever it occurs. Here's a typical encephalotozoan lesion in the brain of a rat. So I've seen it in rats and mice and rabbits, although clearly far more common in rabbits. Not very common in small rodents. It doesn't seem to have any clinical significance, any more so in rats than it does in rabbits. Anyway, be aware that it does occur. Neoplastic diseases in rats are probably more common than probably reported. There are, in my experience, I've seen the entire gamut of brain tumors in rats. This one happens to be a metastatic. This one is a metastatic mammary adenocarcinoma. I'm not sure that grossly you can sort too many of these out. Okay, so you definitely need histopathology to sort those out. A relatively, amongst the tumors that are occurring in the central nervous system, one of the common ones is the so-called granular cell tumor. It used to be called granular cell myoblastoma because of purported origin from myoblasts, and now it looks like it's likely coming from a nerve sheath origin or something like that. It's probably a nerve origin tumor, but these tend to occur as solitary, well-circumscribed masses, usually in the cerebral or the cerebellar meninges. And I mean, here's a smaller one, but they tend to be sheets of large oval cells with abundant cytoplasm that contains eosinophilic PAS-positive granules. And therein lies the ability to make a good diagnosis. I guess I don't have a PAS on one of these things, but these things just absolutely light up. The granules light up with PAS. And again, then glial tumors, probably all the different glial tumors. Astrocytoma probably is, in my experience, which tends to be more focused in Fisher rats than in the other breeds, but they're all represented, sporadically. Okay, we get down to miscellaneous diseases. Certainly an important miscellaneous disease of rats is photoreceptor degeneration, or so-called retinal degeneration or retinal atrophy. And this is light intensity and light duration and temperature related. So those are the variables. Expect to see about 10% of the rats at 2 years of age with this disease under normal circumstances. Again, at one institution that I had worked at, when the pathologist began reading the study, saw a tremendous increase in the incidence of this disease, and went back, retrospectively went back and looked at the study records. And we determined that the animal handlers forgot to rotate the cages on the racks. And so 100% of the animals that were on the upper racks had retinal atrophy. And then there were proportionately lower, the lower animals. And so that's how we went back and discovered that. And if you don't, that's one of the reasons which we rotate those cages on the racks, because the animals that are higher up, closer to the ceiling, are going to get more incident light, and they're going to have a higher incidence of retinal degeneration. Fortunately, the cages were mixed so that the high-dose animals weren't on the top rack, and the intermediate dose on the middle, and the low dose on the low. Otherwise, we might have had a problem interpreting that, right? I mean, we might have killed a chemical or a compound because of what it did to the animals on the top shelf. So again, I mean, you just have to be aware of all of these things a little bit. Okay. Again, just so to appreciate the magnitude of the change that you see, this is a normal rat retina, and this is what you see. This is what it's down to. Okay, this is the entire retina. And again, I'll let you go back and look at that again so that you can appreciate. I mean, here's sort of normal 10 layers, and here's this photoreceptor layer, and then boom, that's what's left. So there is tremendous atrophy in these retinas. And again, another very common and very important late onset nervous system disease in rats is spontaneous radicular neuropathy. And this is primarily it's a segmental primary demyelinization of the ventral nerve roots, and preferentially in the lumbosacral cord and the cauda equina. It occurs in aged rats, and you can see that in some strains of animals, 3/4 to 90% of the animals at 24 months of age will have lesions related to this disease. The clinical signs, if it gets to the stage where the animals have clinical signs, are posterior paresis and paralysis with skeletal muscle atrophy. Okay. Histologically, the lesions are quite characteristic. There is myelin sheath swelling. There's demyelination. We may see macrophages with axonophagia if it's severe enough, and cystic spaces in the myelinated nerves. Okay. And here's a very nice example of this that came to me from a colleague at a pharmaceutical company in Japan. No one's going to have any trouble diagnosing this. This is a Luxol Fast blue stain, and you can see all of these big, large, dilated axonal sheath swelling with axonal degeneration or axon dropout. We may have a macrophage or two in there sort of gobbling this up. And this is, I think, a ventral root from the sacrum. Just up close and personal. Again, you can see loss of axons here. Okay, see here, these are the axons, big cystic spaces. Okay. Pathogenesis is undetermined. All right, urinary system. Viral diseases of the urinary system, none, which that I'm aware. When you get down to bacterial diseases of the nervous system, the kidney is not an uncommon place to find Corynebacterium kucheri. And the way, if you remember the pathogenesis of corynebacterial infection, it tends to be hematogenous dissemination of the organisms. So you may expect to not only see the pneumonia that we see, but you may see metastatic or septic abscesses in distant or in other organs, and liver and kidney are two of the common places that you see that. Here's a cross-section of a kidney, and we'll get close in a minute, but you can see multifocal cortical areas of density. And again, in looking at the cross-section of a kidney, where the lesion is tells me something about the pathogenesis. Okay, if I see, and this would be true for any species, if I see lesions that are in the medulla or in the lower portion of the kidney, I need to be thinking about ascending processes, right? Whereas if the lesions are centered in the cortex, well, the only way I can get into the cortex of the kidney is by the vascular route. Okay, so hematogenous spread to the kidney, and you know this from your experience with suppurative embolic nephritis, and that really is what this is in a sense. Those lesions tend to occur predominantly in the cortex. So here's a Corynebacterium kucheri kidney in which the lesions are predominantly in the cortex. And here we are up close and personal. The response, again, in the kidney is similar to what it is in the lung. It's pyrogranulomatous inflammation, and often there are bacteria present that can be easily visualized and stained, and here are bacteria present here. Mycotic and parasitic diseases, again, not common in the rat urinary tract, but there is a nematode called Trichosomoides crassicauda, which is a group, it belongs to the Capillaria group, or it's a capillariid, and like many capillarias, it sows itself, or its habitat is within the epithelial layer. All right, so you'll see that it forms little galleries or channels within the epithelium, and because it's marginally invasive, there's marginal response to it. So if you think about it from the standpoint of the parasite, it's almost living in the host, but it's not living in it too much, and so it's not stimulating too much rejection or an immune response. There tends to be maybe a little lymphoplasmacytic inflammation associated with it, but not much. And so because it's not causing much damage, it's not causing much response, it's not causing much disease. And those are, of course, the ideal or the hallmarks of a successful parasite, or a parasite that's there but kind of not causing too much damage or risking being rejected. Anyway, it's a sporadic, you may, if urinalysis is being done, you may see the eggs in the urine, and that may alert you to the fact that there are parasites in the wall of the bladder, in the epithelial layer of the bladder, but they generally do not cause much disease or much of a lesion. You're familiar with the capillary plica in the dog urinary bladder. I mean, it's a related parasite. Those of you that have experience with macaques know that it's anatrichosoma is a related parasite that occurs in the nasal mucosa. So there's a whole family of these parasites that are sort of epithelial parasites and don't cause a lot of damage. Neoplasms are relatively uncommon. Nephroblastomas and renal carcinomas do occur sporadically. The exception is in brown Norway rats have a high frequency of transitional cell carcinomas. For instance, the male brown Norways may have a 28% after 2 years, 28% may have bladder tumors, and 6% may have ureteral transitional cell tumors, and in the females, about 2% have bladder tumors, but 20% have ureteral tumors. So the brown Norway rat may be a good model for transitional cell carcinoma. And I don't know what's being done with that recently, but certainly at one time it had that potential. When we get to miscellaneous diseases of the rat, certainly this is a disease that everybody who has even marginal experience with rats will understand, and that is chronic progressive nephropathy or chronic renal disease. It is a major disease problem of rats. It's probably more important than chronic respiratory disease is. It's an age-related condition in many strains, and there seems to be a strong correlation with the lab chow diet that is high in protein. Now, there's a lot going on right now in rodent nutrition about protein calorie restriction and whether or not, you know, the fat rats that we produce on this high caloric diet is an appropriate model in the bioassay or not. Okay, and certainly there has been some research to show that if you control the protein content in the diet, you may be able to decrease the progression and onset and severity of this disease. Okay, so certainly there are nutritional aspects of it. Okay, there may be a relationship to prolactin as well. Okay, not quite as well worked out, but the disease may begin as early as 3 to 6 months of age. All right. It may begin. You may begin to see the disease at 3 to 6 months of age, so it doesn't take long for you to see that. And in terms of clinical signs, I mean, you won't see any clinical signs, typical clinical signs in terms of animal behavior and things. But if urinalysis is being evaluated, the animals will begin to lose protein, and they lose enormous volumes of protein. Okay. And then eventually, if it gets really bad, I mean, they'll have all the signs of chronic renal failure. They'll have elevated BUNs and creatinines, and they'll get hypertensive and have ascites and begin to have the lesions of secondary hyperparathyroidism. What we see grossly, the kidneys become pale. They get kind of a pale yellow discoloration. They may be sort of pitted and irregular and have a granular appearance. You may see little cysts. There may be cystic dilatation of tubules. Okay, and microscopically, the microscopic picture and the electron microscopic picture is dominated by thickened basement membranes, dilated tubules, glomerular sclerosis, and fibrosis, and lymphoplasmacytic interstitial nephritis. I mean, these are all very common lesions that we're used to seeing in chronic renal failure in companion animal patients. Okay, so some of this just kind of all goes together, I think. Here's a nice example of what again, I wish I had sort of normal kidneys. You have to remember that normally the kidney is sort of a kidney color or a liver color, and this is way too pale, and you know, the surface is pitted, and there are small cysts, and that small pitting creates this kind of granular, kind of wet granular appearance, and I'm sure the yellowish appearance probably is related to fibrous connective tissue and edema fluid and all of those things. And microscopically, there is some cystic dilatation here. We're not at a low enough level that we can appreciate the change, but subgrossly. But then we get down microscopically. There is, as you would guess in any animals experiencing significant proteinuria, you'll see lots of hyaline casts, and there is thickening of the hopefully we're going to see thickening of basement membranes. There's some glomerular sclerosis, and here's this background non-suppurative interstitial nephritis. Yeah, look at the thickened basement membranes. Okay, so again, a little bit of interstitial fibrosis. I mean, this has a little bit of everything in it. And then here is the electron microscope indicating this is of the glomerulus, and then look at the tremendous basement membrane thickening, and there's some foot process fusion here. So this is all what goes into the glomerular sclerosis, and it's the damage to this glomerular filter that permits the proteinuria. There are some incidental urinary tract besides chronic progressive nephropathy, and one of those would be like our like canine patients, cystic calculi is sometimes a sporadic problem. They tend to be more frequent in Sprague dollies and in Osborne-Mendel rats. There may be some relationship between this and transitional cell carcinoma. I think it's uncertain at this time. Certainly we'll see obstructive nephropathies. Here are some hydronephrosis and hydroureter. Again, this would be an incidental, obviously an incidental finding. This animal does have functional renal tissue and is probably able to maintain normal homeostasis with a one kidney. Sometimes you get infection in these things, and then we'll get pyelonephritis and pyureter and suppurative inflammation in the bladder as well. And an incidental finding, again, in corn oil studies is periodically you'll see lipid emboli in the glomeruli. You may see lipid emboli elsewhere as well. But animals that are on a high fat or high lipid diet may suffer the consequences of that. I don't know that there's any clinical significance to it. But again, it's something you need to be aware of when you're looking at studies. You know, if this pops up in your, it better be in the appropriate percentages in the control animals as in the high dose for you to have a clear feeling of the significance of it. Cardiovascular system. Okay, there are no viral diseases that are especially impact the cardiovascular system. There are some bacterial diseases, and again, I'm going to discuss Tisser's disease in more depth in mice, but remember that rats get Tisser's disease as well. Although we have a tendency to think of Tisser's as being an enterohepatitis, which it is predominantly. Clearly, there are reported cases of Tisser's myocarditis, and you're looking at one right here. I don't know if you can appreciate that there are, the manifestation is quite similar. I mean, there is histiocytic inflammation, probably some regenerative change here, but you look for the little basophilic haystacks within myocardial cells. I don't know if I have a... Yeah, and clearly there are Tisser's organisms in this myocardial cell here. Okay, so be aware that Tisser's can express in the heart as well in the more common areas, liver and intestinal tract. The other bacterial disease, as you would guess, would be Corynebacterium kucheri. And this is an example of Corynebacterial kucheri abscesses in the heart. This was from an experimental case that I generated. Was when I was trying to make pneumocystis, and what I made was pseudotuberculosis. But tremendous myocardial necrosis and inflammation related to metastatic disease. And here we have an example of myocardial necrosis and inflammation, and here are the bacterial agents. Here are the corynebacterial agents. Miscellaneous diseases in the cardiovascular system, and certainly one of them would be myocardial degeneration, or so-called cardiomyopathy. And this is an age-related degenerative disease that occurs usually after 1 year, although you may begin, as in chronic nephropathy, you may begin to see manifestations of this. I've seen evidence of myocardial degeneration in 90-day studies, okay, in 3-month studies. So the onset can occur pretty early. Males seem to be more frequently affected than females, and then by the time the animals, at least my experience in Fisher rats, is that by the time the animals are 18 months of age, a significant number, I mean in the range of 2/3 to 3/4 of the animals will have lesions. And what you see is myocardial degeneration and necrosis in my experience, you see that less than you see the resolution from that, or the response to that. And the response to that would be fibrous connective tissue scarring or interstitial fibrosis, some lymphohistiocytic inflammation, and then Anichkow cells. Okay. And the lesion seems to be more predominant in the left ventricles and in the papillary muscle. Those are perhaps the active areas, and so that would be where you would tend to see it more. Here's an example of early change, all right? And these would appear as just sort of sporadic areas of degeneration and interstitial inflammation. And this is what you will see in the chronic lesions, okay, as this damage is resolved by fibrosis rather than reproliferation of the myocardial cells. And so you may see very extensive areas of this. Sometimes an adjunctive lesion with this is atrial thrombosis. And if atrial thrombosis gets large enough, it can cause sudden death. So again, I have in my memory that a number of times an animal would have died suddenly on study, and the only significant findings would be at necropsy would be atrial thrombosis and myocardial degeneration. So the assumption was assigning cause of death, it was related to that. A second miscellaneous disease that may occur is this so-called endocardial disease. This is an age-related, low-incidence disease of uncertain etiology. Perhaps 1 to 7% of the animals on study may exhibit this. That seems a little high. What you will see is grossly is a whitish thickening of the endocardium in the left ventricle, sort of a sort of endocardial fibroelastosis, which has been the term in companion animals. And here you can see this diffuse proliferation of this. The concern would be confusing this with neurofibroma or rhabdomyosarcoma. Probably more, this neurofibroma has been described in the rat heart, and that needs to be differentiated. It is a diffuse proliferation of fibroblast-like cells, well set off from the myocardium, and again, this may also stimulate thrombosis as well. And there's a nice example of that. So almost eroding into, but pretty much confined to the endocardium. Again, you can see in an isolated way, looking at this, that this could be a very well differentiated neurolymoma or neurofibroma or nerve sheath origin tumor. So, again, another miscellaneous disease of the cardiovascular system would be granulomatous peritonitis, granulomatous pericarditis secondary to gavage accident. All right. And this usually is a sporadic occurrence, although it can appear, as I can assure you, it can appear as an epizootic. And I've made this disease, and probably everybody else who has any experience gavaging rats, I don't care how careful you are. I had an interesting experience with it here just a year or two ago on some mammary tumor studies that I was looking at the effects of nutrition. And early on in the study, we created a multiple cases of this. And obviously, it's all related to our gavage technique, okay? So it looked like we were having an epizootic of something because these animals were dying, but on thorough post-mortem examination, the findings are always quite similar, and that is you get tremendous granulomatous to fibrinous inflammation around the heart and in the pleural cavity, and in some cases we inoculated streptococci into the pleural cavity, probably either from the tip of the gavage needle, or we introduced it from the oropharynx, pushed it down into the esophagus and through the wall. Okay, but I mean tremendous growth of gram-positive strep and all the inflammation associated with that. So it can happen. And up close and personal here, if the animals survive for a while, you may get to see granulation tissue and all of those things. Typically, the animals sort of don't do well for a while. And so, you know, sort of their weight gain goes to hell, and they just kind of look sickly and ill and hunched up. And I think in the last study we had, nobody died. I think we pretty much put everybody down, but they were close to dying anyway. But in such a case, if they go on for a couple of weeks or so, then you'll see granulation tissue and chronic inflammation and all of those things. Hemopericardium is sometimes sporadic incidents in the cardiovascular system, and almost always related to, as you would guess, a heart stick for some reason or another. So if you're going to heart stick, if your experimental protocol is doing intracardiac bleedings or something, and the animals are to survive, this isn't done terminally, sometimes improperly done, those animals suffer hemopericardium and will die in tamponade. So it's very important for us as pathologists, you know, not to practice pathology in isolation. That's why it's important for you to review protocols, to be in part of that protocol planning session, to know how the animals were being experimentally manipulated, because that's going to help you interpret your findings. And I think it's a mistake for us to simply say we're histopathologists and our involvement in the studies is simply looking at the slides somebody brings to us. And I don't think you're going to do yourself justice or the people you're supporting justice. You need to be actively involved from the start, so that you know that if you had suddenly had 2% of the animals on study that had this lesion, and there's no history of intracardiac puncture, then you've got a problem on your hands, right? It would be the same thing with where you start seeing streptococcal pleuritis in animals, and there's no history of gavage in these animals, you've got a problem on your hands, right? If, however, the animals are being gavaged, well, then now you're not so concerned about seeing streptococcal pleuritis. So it's very important for us to know the context of how the animals are being manipulated. Again, another incidental disease of the cardiovascular system is so-called Polyarteritis Nodosa or Periarteritis Nodosa. And this is a very interesting inflammatory disease of the muscular arteries, especially those in the mesentery. The human disease is regarded as a hypersensitivity or immune complex disease, and it's quite reasonable in looking at the pattern of the histopathology. It's quite reasonable to postulate that it may have a similar pathogenesis in rats, but that's uncertain, and the etiology of this is not known, all right? Grossly, what you see, though, is quite characteristic, and that is these enlarged, tortuous, thick-walled, nodular vessels. Now, the lesion may be very segmental, and in fact, in my first experience with this, and I don't know whether it was just in Fisher rats. It's described in a number of strains of rats, whether it was the Fisher rats or the Fisher rats that we were getting from Charles Rivers at the time. But quite commonly, we would see these little 5 or 6 millimeter sort of grayish red sausages in the pancreatic artery. And it was just this little segmental part of the pancreatic artery that was involved, okay? It may be more extensive than that. So anything that looks like a nodular, thickened artery needs in the mesentery of a rat. This needs to be considered. Microscopically, what we see is fibrinoid necrosis and neutrophilic and lymphocytic and plasmacytic, histiocytic inflammation with a fibrosis and thrombosis. All right. And it's, when you think about it, I mean, those are the lesions that you would expect to see with chronic vasculitis anyway. So the concept of this being hypersensitivity mediated is very real, I think. This is about the most extreme example of this I've ever seen. You can see all these little nodules here in the mesenteric arteries, okay? This is not my usual experience. Usually it's much fewer, much smaller. Nonetheless, though, it's a finding that you have to deal with as it turns up. I mean, again, suppose 20% of the animals in the high dose group had this, and 1% of the animals in the control group had this. You'd have to be concerned that the compound under study may be doing something to upregulate or enhance expression of this disease, and that's in the safety assessment business, that's what we're here to do. We're here to recognize those lesions and postulate how could our compound be increasing or enhancing the incidence of that. That could be a very important question. The compound could be doing something to cause hypersensitivity vasculitis, and that's the result of what we see. Here again, is very typical from my first experience with this disease. Here's the pancreas, and look at the size of the pancreatic arteries here. I don't have a gross to show you, but look, this is just tremendous increase. I mean, out of all proportion, what it should be. And this is what we see histologically, and again, it's a mishmash of lymphohistiocytic and neutrophilic inflammation with fibrous thickening of the tunica media. The hemic lymphatic system, okay, will be next. Sort of my artist's way of indicating hemic lymphatic. How else are you going to do it? I don't know. Viral diseases. Remember that SDAV, the coronaviruses, specifically have been shown to cause lymphoid hyperplasia, but really, I mean, if we're going to talk about lymphoid hyperplasia as being a lesion, then lymphoid hyperplasia can be a response to a lot of different infectious agents, okay? Bacteria, but other than that, though, there are no viral diseases specifically expressed in the hemic lymphatic system, and the same would be true of the bacterial diseases. Once you get by the Carinibacterial abscess, and again, you have to include salmonellosis in here, although we'll talk more in depth about salmonella with mice than we will in rats because it occurs more commonly, but there is a frequent expression of it in spleens, and so we'll deal with that later. Mycotic and parasitic infections, none that are of specific importance, although if you get down into the textbooks, you'll find that there are some hemotropic parasites that do occur. We get down to neoplastic disorders, and then we do have some common diseases that we have to deal with, and one of them is Lymphoreticular Neoplasia, the lymphomas and the leukemias. Clearly not as diverse and as common in mice or in rats as they are in mice, but there's no question that lymphoma and leukemias do occur. Thymoma occurs at a low incidence, and this might be an example of, I think this is a thymic lymphoma. I don't think it's thymoma, but thymoma could look like that. But this really is the disease that occurs with any frequency at all, and that would be the so-called large granular lymphocyte leukemia. And again, the incidence of this is quite strain dependent. It's virtually non-existent in Sprague-Dawley rats. It occurs with some moderate to low to moderate level in Wistar-Firth rats, but it's a disease it's a tumor that appears to be increasing out of control in Fisher rats. When I started studying this disease in the early 80s, the incidence levels that I think I was looking at were probably in the 20 to 25% range, and some discrepancy between males and females. Now the people that have been tracking this disease very carefully at the NTP tell me now that the incidences are in the 40% range, and that in some smaller groups in small groups of rodents it may be well over 50%. So there may be something happening in the Fisher rat genome that is permitting more frequent expression of this disease. Anyway, if you work with Fisher rats, you're going to have to deal with Fisher rat leukemia. Fortunately, it's really sort of a no-brainer to diagnose, I think. I mean, the triad of signs is that the rats are pale, because they're markedly anemic, they're icteric because they have liver disease, and they have tremendous splenomegaly. So pale icteric rats with palpable enlarged spleens all have LGL leukemia. The normal Fisher rat spleen should weigh about 1 gram, and these spleens will go up to 25 grams in size. Okay, integumentary system. There are no viral diseases of the integumentary system. There are a variety of non-specific bacterial diseases that may cause dermatitis, and principally strep and staph, and these would be of sporadic occurrence and generally secondary to wounds. Do I have a, yeah. And here's an example of, I think this is a staph dermatitis secondary to trauma. Mycotic and parasitic infections, there is again a small range of these that have been described, some of which you'll have to deal with. Remember, as in many animals, dermatophytosis does occur in rodents. Almost always it's Trichophyton menographides rather than Microsporum, but nonetheless dermatophytosis is not quite as common as it is in mice, but it does occur, and the lesions are quite typical. There should be no problem in making a diagnosis microscopically because you see suppurative folliculitis and furunculosis, and you see the mycelia and the spores adhering to the hair follicles. Okay. There are several acariases, one of which is Radfordia and Cyphera, and the other which is Ornithonissus baccati, and I believe this is the Ornithonissus mite here. But again, what you would see grossly would be sort of maybe erythematous, scruffy skin, and evidence of dermatitis. Okay, and I wish I had gross to show you, but I don't. Neoplasms, and the rats have a lot of cutaneous neoplasms. A quite common one, which I referred to earlier in the talk, is Zimbel's gland, the Zimbel's gland tumors. And Zimbel's glands are modified sebaceous glands that occur in the external ear canal. And the Zimbel's gland tumors are almost always diagnosed by their location. Okay, so large swellings immediately below the ear, cutaneous swellings, are probably expanding Zimbel's gland adenomas and carcinomas, and depending upon how large they are, they may be quite ulcerated and hemorrhagic. I mean, that happens with large cutaneous masses in rats anyway. This is the, again, in trying to show this apposition, you can see that, I mean, here is the external ear canal, here is the ear cartilage, here's the external ear canal, and here is this large tumor arising from these modified sebaceous glands at the base of the ear. Okay. I can't give you any incidence figures. They're relatively uncommon, but again, you know, commonness is a function of how many you've seen. And I mean, I've looked at tens of thousands and thousands of rats, and so to me, Zimbel's gland tumor is a kind of a common tumor, even though I wouldn't be surprised to have somebody tell me that, you know, 0.2% of the rats, control rats have this. I mean, to me, I see it. It seems distinctive, so it seems common. There have been studies in which carcinogens have readily induced this tumor, so it does, it does impact. It is important to know those. Again, a variety of these skin tumors are often, many of these are glandular epithelial cells that are modified sebaceous glands, and the diagnosis is often based upon location. Okay, I mean this is either a preputial gland tumor or a clitoral gland tumor, depending upon whether it's a male or a female, but the tumor occurs in the same location. Okay. This is an exorbital gland tumor, so it's one of those lacrimal glands occurring inside the orbit. We're looking sort of down on the animal. It's kind of hard to get an appreciation for that. Epithelial tumors so papillomas and squamous cell carcinomas and basal cell tumors are relatively common. Sarcomas are probably more frequent than epithelial tumors. The classification of cutaneous sarcomas in rodents is a crapshoot. Lots of controversy, lots of changes, and I'm not going to go into it here. And also, I'll just briefly mention, because you see it in the skin, probably the most common skin tumor we see in rats is a reproductive tumor, and that is the mammary fibroadenoma. All right, I'll mention it in skin because you have to deal with it as a lump in the skin, but I'll show you a picture of it when we talk about, in a minute, when we talk about the reproductive system. Okay, miscellaneous diseases in the skin, and probably the one that comes to mind most readily is ringtail. It's probably not a very common disease anymore. It clearly is a disease that has an environmental pathogenesis or is related to the environment. and the environmental variable that it's related to is low humidity. Animals that are living in a less than 50% humid environment will express this disease. It's usually a disease of young rats, and it's so-called ringtail because of we see these annular constrictions of the tail grossly. Microscopically, it's not very impressive to see it, and I'll show you an acute manifestation. But edema, spongiosis, necrosis, separation of the epithelial cells that may result in spontaneous amputations, and the pathogenesis, of course, invokes hyperkeratosis and perikeratotic responses, and this is what it looks like. Here's a nice example of how humidity affects this. If you look at, this is these figures compiled by a study, but humidity over 60%, no incidence of all, and then as it drops down to 20, you can see more and more and more and more of the animals are affected, so it absolutely is relative humidity based. And here's the gross, here's these annual constrictions you see, and maybe a little amputation here, hence the name ringtail. And then we get down to the microscopy is not very impressive. We see the spongiosis and loss of separation of these cells in the prickle cell layer. And here just up close and personal, we see this almost like acantholysis. Okay. Good. Second carousel. Take a break. Reproductive system is next, and there aren't a lot of viral diseases that express themselves in the rat reproductive system. I would mention that Kilimrat virus does cause testicular necrosis, so that's been reported with Kilimrat virus infection. I don't have lesions to show to you, but generally not much in the way of viral reproductive disease. The story is a little bit different with bacterial diseases, and that is that there is a genital form of mycoplasmosis that occurs in rats. And as in the other forms of mycoplasma infection, it tends to be expressed as a subclinical endometritis that may go all the way in severity to frank pyometra. Other than that, there aren't clinical signs associated with this, so this may be an incidental finding for you at necropsy. What you may see grossly is normal to cystic endometrial hyperplasia. My experiences and the literature reports that there may be gross lesions in only about 30% of the cases, and probably the most frequent lesion is salpingitis and oophoritis. Histologically, what we would see is suppurative to neutrophilic inflammation in the lumen of the uterus and the uterine glands. And there may be epithelial hyperplasia and squamous metaplasia, quite similar in response to mycoplasma in other organ systems. And a note of interest is that there may be vertical as well as horizontal transmission in this disease. Not of concern to you if you're buying your rats, but some of you may wind up working in production facilities someday. And that may be a problem. You diagnose Mycoplasma pulmonis or genital mycoplasmosis in your colony, and you're going to have a problem because could be vertical transmission of this disease. And here is an example of the suppurative salpingitis that occurs. I mean, here we have the tip of the uterus here, and here is the oviduct, and you can see that it is markedly dilated and white and opaque, and there's purulent inflammation in there. Sometimes you get to see frank pyometra, as in this case. So here is the unopened, enlarged. Sometimes I know it's hard to get oriented, but here is unopened, enlarged uterus and cut open, and there is pyometra in rats, probably almost always related to this infection. And let's see here. Approximately 20% of the infected females are infertile, right? So it's an important bug. 60% of the infected females have decreased fecundity. So even in subclinical infections, in your production facilities, you start seeing a fall off in fecundity, there could be a problem. All right. And I think this is, I'm going to back up. Okay, mycotic and parasitic diseases of the reproductive system, none worth mentioning. Neoplasms of the reproductive system, and there are a couple that we need to be concerned with. One of them is the so-called endometrial stromal polyp, sort of a neoplasm, okay? And I don't know if I'm going to have a picture here for you or not. Well, let's see. What these look like are segmental but relatively normal appearing swellings of one or both uterine horns. And histologically, there is variable cellular stroma and glandular proliferation. Okay, that's not what this is. I believe this is a cross-section of suppurative endometritis in the rat. And maybe I've got a slide out of order here. The second neoplasm that I want to mention that is extraordinarily common in rats, and that is mammary fibroadenomas. Very, very common, primarily in females, with a dramatic increase in incidence after the 18-month landmark, okay? And they may occur anywhere from the axillary region, as this one is, to the inguinal region, as this one is, okay? And they appear as smooth, firm, lobulated subcutaneous masses that can get very large and ulcerate. And although these don't represent by themselves a threat to this animal's life, they are a threat in a sense that if they break open and ulcerate and get infected, they may require that you put that animal down or delete that animal from the study. I mean, the Isla Cook people will be on you all over the place. And again, just recently, in the last couple of years, I've had some grants looking at mammary cancer because it's a hot, it's politically hot and biologically an important problem in our culture today. And in working with rodent models of carcinogen-induced mammary cancer in which we make carcinomas, not fibroadenomas, but the problem is the same, and that is a mammary mass. When these things get to a certain size and they break open and ulcerate, the laboratory animal veterinarian is on me like a buzzard on a gut wagon to put those animals down, and that represents lost data point for me. Also, the other problem, when you start thinking about it, and especially in dosed feed studies, as these things get big, all right, you have to ask yourself, with time, you know, what am I feeding? Okay, am I feeding the rat or am I feeding the tumor? All right, these things will get much bigger than this. So the question becomes, well, you know, the compound is dosed at a certain body weight, whatever, but at a point in time, the tumor represents a significant amount of that animal's body weight. And so am I still delivering the same dose of compound to the rat because I'm delivering that compound to the tumor as well, right? So they represent some management problems for you, not that they directly impact the health of the animal, but they're very common and you're going to have to deal with them, and what you'll have to do is either take animals out of the study, which we don't like to do. Histologically, they vary quite a bit from being, you know, very fibrous to very adenomatous and anything in between. And I don't know that anybody makes any distinction, but I mean, this is the typical both fibrous connective tissue and well-differentiated acini, some of which have a secretory product in them, okay? So quite a range of histological characterization. Ovarian teratomas occur sporadically. Probably the most common tumor in the ovary in aging rats, but they're pretty rare in amongst themselves. Okay. I'll briefly mention uterine adenocarcinomas. They're not common, but in hand-Wistar rats, they're a major cause of female mortality, okay? And they cause, as you would expect they do in humans and in rabbits, widespread transcelomic carcinomatosis and pulmonary metastasis. So not common in the strains of rats that I have lots of experience with, but well reported in hand-Wistar rats as being a major cause of mortality. Again, another example of how different strains of rats may express different diseases at different incidences, okay? What we're looking at here is Leydig cell tumors or interstitial cell tumors of the testis. These are extraordinarily common in Fisher rats. Probably greater than 95% of the animals at 2 years of age will have this tumor, all right? And so the significance of this becomes how well are we evaluating compounds for testicular neoplasia in this rat model? Well, it turns out for some metabolic reasons that it's probably okay that many compounds aren't impacting on the testis, but very often the way we determine carcinogenesis in a study is by looking at an increased incidence of normally occurring tumors. Well, when you've got a tumor that occurs at a background level of 95%, that doesn't give you any leeway to decide that the compound caused testicular neoplasia or not. And that's why the people who have been tracking the incidence of Fisher rat leukemia are getting alarmed by the Fisher rat leukemia, because it's getting up there to where it is. I mean, I very frequently get asked to to review studies in which there was a high level or a high incidence of fish rat leukemia, and the question always is, did the compound cause leukemia, or is this just the normal incidence that's upregulated? And it's a very sticky issue. Anyway, these are very common in fisher rats, less common in other strains. Quite frequently what you see is multifocal yellow-white nodules in the liver, in the testis, well illustrated here, that these testes often are enlarged, and because the tumor may cause vascular obstruction, there may be infarction and hemorrhage in this tumor as well. And histologically, I think, yeah, I mean, this is pretty typical what you see. So here's lots of these nodules often coalescing, crowding out the other tissue, okay? So histologically, the cells look very much like Leydig cells do in the normal testis, so there's no problem making that diagnosis. And just another common, these are placental attachment sites. These are multiple symmetric uterine enlargements. This is a normal finding in rats postpartum, and just not so that you're aware of that and don't get excited and worry about some bizarre disease syndrome. Okay, musculoskeletal system. We're getting down to the end here, troops. There are no viral diseases that I'm aware of that impact primarily in the musculoskeletal system, but there is a species of mycoplasma called Mycoplasma arthritis under the designation of bacterial diseases that is usually expressed as an endemic infection in a few rats. Okay, so again, it's a common theme with mycoplasma species, endemic, primarily latent disease that may be reactivated by stress, and probably more frequent in young animals because they handle stress less well than animals with a more mature immune system. It's primarily the tibiotarsal joints and radiocarpal joints that may be involved, and what we'll see would be some erythema and swelling over those joints. Some decreased in range in motion, if you can measure range in motion in a rat, and it may progress to ankylosis with deformity. Okay. And again, a common response to arthritis of many different causes is exuberant periosteal new bone, or PNB, proliferation. Okay. The lesions are initially suppurative inflammation in the tendon sheaths that may progress to suppurative arthritis. And destruction of the articular cartilage. I don't know if I have any to show you. I guess this is an example, but it doesn't really show the lesions very well here. I mean, here are the joints. It doesn't really show that lesion very well. And I don't know if I have. Yeah, I don't have that. This is something else. Again, bacterial diseases in the musculoskeletal system, we need to consider always metastatic abscesses from Corynebacterium kucheri. And one that we haven't talked about would be streptobacillus, and I don't have any slides to show you that, but streptobacillus may cause arthritis, suppurative arthritis as well. Usually that's in the vertebral joints or the tail. Mycotic and parasitic infections of the musculoskeletal system are rare or of no importance. Neoplasms are pretty rare. You will see osteoma and osteosarcoma in some animals. They do occur. I don't know that there is any strains that have a high incidence of that, but you will see those. Probably the most common musculoskeletal disorder that I see in rats is a miscellaneous disorder, and that is fibrous osteodystrophy related to chronic renal failure. So because you see a lot of chronic renal disease in rats, and it goes on a long time, as you're looking at bones in these rats, expect to see the lesions of renal secondary hyperparathyroidism. And here we see this fibrous osteodystrophy here. Endocrine system. Okay. And in the endocrine system of rats, essentially only neoplasms are common lesions. All right, so I'm unaware that any of the infectious diseases impact there. So expect to see pituitary tumors. These are extremely common. Again, somewhat strain dependent a little bit, but they tend to increase with age. The females tend to have more diseases or more lesions with males. There may be some relationship to mammary tumors. And clearly the most common disease are the benign tumors of chromophobes or chromophobe adenomas. And again, I hate to make puns, but this is a no-brainer in terms of diagnosis, and that is large masses protruding from the cella turcica. Some of them will be carcinomas, but most of them will be adenomas. And these can get large enough that I think they may cause some CNS signs. All right, so not all CNS signs in rats will be mycoplasma related. So in the older animals, you need to consider chromophobe adenomas as one of those. And this is histologically, there's nothing unique about these. I think this is a chromophobe adenoma in any species you would look at. So diffuse proliferation of chromophobic, homogeneous chromophobic cells in a sort of a typical endocrine packeting. That is islands or cords of more or less epithelioid cells with a thin fibrovascular packeting or stroma around them. What I like to call endocrine packeting would be characteristic of this. Okay. Thyroid tumors are also common with the ultimobranchial or C-cell tumors are probably more common than the follicular tumors, but both occur. I'm not sure grossly that you can appreciate the difference. You have to look at them histologically, but here's a little piece of trachea, and there's thyroid on this side, and then here's a thyroid with a big thyroid tumor in it. And here, this one happens to be follicular. Okay, a follicular tumor. Adrenal tumors are common. Both cortical tumors primarily adenomas, but pheochromocytomas also occur. I'm sorry, we're still on. Here is. This is unusual. This is a parathyroid tumor, right? Parathyroid tumor. So here is thyroid, parathyroid tumor. Not particularly common, but I've not seen them very often. Here is the adrenal cortical tumor. Well, you just recognize this as an adrenal tumor only, and then microscopically, this is a cortical tumor that tend to be very well differentiated. And then this is the pheochromocytoma, a medullary tumor. Again, we see endocrine packeting. And then uncommon, but again, uncommon is a very relative term, would be tumors of the pancreatic islets. These tend to be single, well-circumscribed masses with a typical history. Many of these, and again, a number of years ago, Chuck Capon and I published a short paper on some of these, and had at our disposal some monoclonal antibodies against insulin, and we were able to determine that a significant number of these islet cell tumors in the rat contain insulin, but there's no evidence that these animals ever have hypoglycemia. So I don't know whether they're secreting inappropriate levels of insulin or not. Okay. Okay, and lastly, I don't have an icon for it, but lastly I'd like to consider just very briefly body cavities as an organ system. and because there is a neoplasm that occurs in the peritoneal cavity in rats. No viral diseases express, no bacterial diseases other than the streptococcal pneumonia or the streptococcal infection that we see in gavage accidents that may cause pleuritis. Okay. No mycotic or parasitic diseases that impact there, but there is a neoplasm and mesotheliomas impact in body cavities in rats, and they're uncommon, but they are characteristic in the peritoneal cavity. And what you tend to see is quite typically in the less florid expression would be kind of this white nodular granularity on the epididymis of testes in males, clearly as an incidental finding. But in the florid expression of the disease, we may see this sort of irregular, lumpy, bumpy, granular proliferations all over the serosal surface of the body cavity in animals and adhering to the body wall. And I think this is, here's a nice example of this one without all the effusion in there. These multiple little granular growths. Okay, often, again, in florid cases, we may see copious turbid ascites fluid related to the transcoelomic implantation of the nodules.